Hello and welcome to Single Payer Radio. I'm Paul Hoppe, broadcasting from the Hawthorn building in Louisville on the WFMP 106.5 Forward Radio Community Network. Our program's there every Monday at 2 p.m., Tuesday at 7 a.m., and Wednesday at 11 a.m. And we also stream our show on SoundCloud. The show is a project of Kentuckians for Single Payer Health Care in conjunction with Physicians for a National Health Program through its Kentucky chapter. We produce this program because we believe healthcare is a human right. We advocate for a national, not-for-profit, publicly funded, single-payer healthcare system for everyone. The views and opinions expressed on our show are those of the speakers and not the station. Our station relies on volunteers like myself and your ideas and donations to keep us on the air. Today, our show is a discussion on a troubling report recently released on the ranking of the U.S. healthcare system compared with other industrialized nations. It will be moderated by Kay Tillow, our chairperson. So let's get started. Kay?
Okay. Well, there are five of us here with you with Kentuckians for Single Payer Healthcare. I'm Kate Tillow. I'm the chair of that wonderful group that's been going for about 20 years now, working to educate and advocate for a national, not-for-profit, single-payer healthcare system. So I'll let the other four say who they are, and then Hamza will lead off about this survey.
Okay, I'm Paul Hoppe. I've been with Kentuckians for Single Payer Healthcare for about 4 years now.
And Harriette?
And I'm Harriette Seiler, and I found out the other day that I have been with Kentuckians for Single Payer for 17 years. So I'm one of the oldsters here, but we've got some young people with us today.
And Evan?
I'm Evan Hawthorn. I'm a second-year student at the Kentucky College of Osteopathic Medicine. I'm new to Kentuckians for a Single-Payer healthcare program, but I am a member of SNAP and the president of the local SNAP chapter at KICOM.
And Hamza?
Hi, I'm Hamza. I'm a second-year medical student as well at the University of Louisville. I joined this group recently in the summer, and I got in touch after I was a New England Physicians for National Health summer intern this past summer. Okay, so the report that we are discussing today was put out by the Commonwealth Fund, an independent, nonpartisan research institution that aims to promote a high-performing, equitable healthcare system. They looked at 10 countries around the world, 10 industrialized countries, and compared their healthcare systems using over 70 health performance metrics, where they group them into 5 areas: access, care process, administrative efficiency, equity, and health outcomes. The 10 countries that they looked at included Australia, Canada, France, Germany, Netherlands, New Zealand, Sweden, Switzerland, UK, and finally, the United States. And so putting together this report and looking at overall metrics, they found that the highest rated countries included Australia, Netherlands, and the UK. But the troubling part of this report was that the US is an outlier in a number of categories. And not only that, the US has some of the highest healthcare spending of all of the industrialized nations throughout the entire world. And so although there are pros and cons to the systems that every country has, the US consistently was an outlier in a number of areas, which is very troubling given the current state of United States healthcare. And so some of the things that the report talked about, Americans faced the most barriers for accessing and affording healthcare. They looked at affordability and availability, but good examples of that included Netherlands, UK, and Germany, where they found low cost related barriers, minimal out-of-pocket healthcare expenses, and universal coverage that only came with small co-payments. This is particularly troubling given that 26 million are still uninsured in the United States and at risk for larger trends of costs. The US surprisingly was high in terms of care delivery process, which includes things like prevention, safety coordination, patient engagement, sensitivity. But US physicians and patients were like the most likely to face hurdles related to insurance rules, billing disputes, and reporting requirements, where other good examples include countries like Australia, the UK. We also trailed really bad in equity in terms of healthcare access and experience. And somehow the US lives the shortest lives and has the most avoidable deaths out of a number of countries. So the ending of the report was aimed at not only comparing the United States, but also offering examples of their lessons that we can learn from other countries. Things like equity, administrative efficiency, access. We can look to countries like Australia. In terms of access as well, we can look to the Netherlands, and then sort of went into some recommendations of why the US is the way that it is at the end. Some reasons that they gave were lack of investment into primary care, lots of administrative inefficiency when it comes to the United States due to the large number of private insurance payers, lots of social policies and influence that place stress on the healthcare system, things like gun violence, racial discrimination, drug overdoses. And then finally, one of the things I mentioned was underfunding and decentralization of national public health systems.
Oh my goodness. Well, and I read a sentence. Yeah, thank you, Hamza, for that. But I read one sentence from Health Exec. Apparently, that's a journal that goes to outcomes-driven healthcare leaders, which I am not, but the sentence was shocking. It said the US ranked dead last overall in these with these 10 countries, the advanced what did you call them? Industrialized, I guess, nations.
Yeah,
And
go ahead, finish, Harriet.
well, no, I just wanted to say that, and then I'd like to go through some of the points, and I mean, Hamza mentioned we have the highest costs, and I think overall we have the worst outcomes, except maybe in a few categories. So I'll probably butt in again, but carry on.
And it's shocking, I think, I think most people in this country don't know this, that when Hamza uses the very proper word outlier, it's not clear until you look at the graphs as to how far removed we are from the norm for other countries, that they're doing so much better in health outcomes and life expectancy, in cost and access and equity. You would think that our Center for Medicare and Medicaid Services brags so much about what they're doing for equity to end the disparities based on race and income, et cetera. Well, it's not working. This survey shows that we come in at the very bottom on equity as well as these other things. I think the other thing is that if people knew this, it could very much help us to get there, because when people think, well, we're doing the best that can be done, then you don't do anything. But if you know that your country is behind all of the other industrialized wealthy countries, and they're doing much better on ending unnecessary suffering and unnecessary deaths, then the demand arises, we have to do something to fix this. That's why I think it's important for the people to know where we stand in terms of these particular items. Hamza?
I think you sort of nailed it, where there is a very big dichotomy of, if we have such worse outcomes, well, surely it must be we are not working on it and we're not spending enough. But as you pointed out, that we somehow spend more than, we spend like double of what like the next industrialized country spends, and somehow yet we still have the worst outcomes. And I think another thing you really mentioned, or that it's good that you emphasized, is sort of like lessons we can pick from other places. Or this is not the best way that we can go about doing it. There are examples that we can take from other countries of like, yes, this works, yes, this doesn't work. And in particular, administrative costs. You know, it highlights the US as being some of the like worst examples of having to have such huge billing departments, having to track so many insurance companies and so many plans, which wastes resources compared to those that could be invested in improving the health of others. And another particular bad example of administrative costs is Switzerland, as the report pointed out. There's a fragmentation of the sort of delivery. And so, you know, we can use examples in order to point out why things are bad.
Yes, and Paul?
Well, we can't ignore the elephant in the room, and the simple fact is that our healthcare system is a for-profit system. These other countries are not, and that is the huge difference in my mind, and I think in this group's mind. We talk about that all the time.
That's true. Harriette?
Well, and just to add to that, the you know, we talk about or I've read somewhere that our system is called a multi-payer system, which just complicates everything. And most of these other countries are single payer or some version of single payer, where the national government really is the insurer. And, you know, people say, oh, well, you know, the government, they'll mess everything up. However, I mean, if the rules are set and rules are laid down so that the government can't mess it up. I mean, if you look at our Medicare, basic traditional Medicare is very well run and has low administrative costs. Now, I think Evan probably can add to this too.
I was just going to say that I think nothing exemplifies that difference more than how similar Switzerland performed on the administrative efficiency metrics, because they did mention the report that Switzerland's healthcare system's fragmented across the many cantons. There are 26 of them, and they perform very much in the same way that states do in the US, where each one has its own specific regulations for what things cost and how things get repaid. And that fragmentation just leads to administrative burden and overpayment and delays, very similar to the way that it does in the US.
Yes.
But they must be controlling their profits some. I mean, I'm not sure. I know in some countries like Germany, there are some private insurers, but they're very controlled.
Well, I think that in Germany, they don't allow them to make a profit off of the health insurance. So it's so highly regulated that it really can't be called a private system. And I did see that in Germany, they limit the out-of-pocket expenses to 1 or 2% of your income. And you know, we in this country, we say that you're underinsured if your out-of-pocket expenses are greater than 10%. But most people pay huge amounts. And, you know, that's really, it's not just our uninsured, it's this group of underinsured that is making our system do so badly, because so many millions and millions of people who have coverage can't afford to use it because the deductibles are so high and the co-payments are so high that people are just really only nominally insured. They're insured in theory, but in practice, they are unable to access the care, or they limit themselves because of the cost. And it's phenomenal. I think we saw figures in there of how much people who are in the exchange of the Affordable Care Act can have a deductible of, what is it, something like 18,000 for the family?
Yeah, it's 9,450 for a single plan and 18,500 for a family plan.
And that's the deductible in a marketplace plan, like in an ACA plan? My gosh.
I think that's it. Is that right, Evan?
Yes, that's the cap.
So it's huge. I mean, nobody has, a few people, a couple of billionaires have that kind of money laying around, but the average family doesn't have $18,000 on hand to put into that. So that's what accounts for the high levels of medical debt or people going without. Paul?
Yeah, going on what you just said, the United States healthcare debt is the number one cause of personal bankruptcy. We have a huge number of people that file bankruptcy due to the crushing medical debt that they suffer. If you compare these other countries that we're talking about right now, the incidence of bankruptcy due to medical health is virtually non-existent.
Right. I'm originally Canadian. And I mean, I grew up in Canada and went to college there and everything, but then I married an American and moved down here. I've been very happy, except with the healthcare system. But anyway, I know that no Canadian ever gets a medical bill in the mail. They may pay some co-pay for pharma, but they're even working on that, and they're working on dental now. But just imagine never getting a doctor's bill. And I mean, even things like physical therapy after a knee replacement, all of that is covered. But Hamza, yeah.
And I think one of the points brought up by Kay is fairly important, where the sort of deterrent effect that it has on people seeking care in the immediate. And so lots of these problems end up spiraling where they don't take care of that knee. They don't see somebody for that chest problem. It spirals and spirals, and it gets to a lot worse. And the problem is that it gets a lot more expensive later as well. And so it just keeps going and going. Not only for the individual is that a dramatic problem because it leads to these chronic conditions, but additionally places a larger cost on the healthcare system. We're now, having to deal with those acute problems, chronic problems, rather than just the preventative service that we could provide earlier.
Mm-hmm. Certainly that's true of things like cancer, where early detection is just absolutely crucial to the ability of a person to survive. Paul?
During our last meeting, Dr. Flynn brought up the fact that there's so many women who are getting their regular mammograms, but at the point that something shows up and they're encouraged to take further tests to see what's going on, they actually can't afford the co-payments that are required for that follow-up care, and they never get it, which results a lot of times in advanced cancer and all the ramifications of that.
Right. I meant to look that up. Apparently it was a short article in the Courier about women not getting follow-up to mammograms.
Right. I read the article. It basically says that there are more advanced tests that may not be covered by your insurance company, and that the preliminary mammogram isn't sufficient in many cases to determine, but people don't go through all of it because they're then, they run into the prior authorization. An insurance company says, we're not going to authorize that, or we don't think that that's necessary, so we're not going to pay for that. Evan?
And that's obviously a really important facet of treating cancer or preventative screenings catching it before it progresses to a more aggressive stage. But it also affects things that are much more common, things like hypertension, diabetes, sleep apnea, that are quote unquote benign enough when they begin that people put off seeking treatment for it because they can't afford it. And then it progresses and you get a whole long list of sequela from it, that it worsens every aspect of your health, and it's then much more detrimental. It's much more expensive to get treated. It requires inpatient stays a lot. It's a burden on every part of the healthcare system.
True, that's true. And see, part of the problem is that expense is built into a system that's been designed by the insurance industry, so that we're fighting this problem, is that the insurance industry and much of the academic community have defined the problem in our high cost as overuse of the healthcare system. And on the basis of that, they have written into the ACA and other laws and into the insurance industry policies efforts to stem that overuse, to keep people from overusing, to keep doctors from overtreating, etc. The problem is they have the wrong diagnosis. We are not getting as much care in the United States as people are in other countries. We are in the hospital fewer days, we have fewer physician visits because of this insurance company barrier that sees going to the hospital or going to a doctor as a loss of profit. And they have managed to get that thinking, that ideology written into our laws, so that that's the problem. And that's, we did get, some coverage for preventive care written into the Affordable Care Act, but you can see from the mammogram situation that it doesn't work very well. I know we had the same problem when people went for colonoscopies, and then the insurance system will say, well, we had to remove a polyp, so that wasn't preventive, that was something else, and then people get charged for that. But we have a whole system structured around becoming a profit-making system for the insurance industry, and many of the hospitals and the pharmaceutical companies, et cetera. And that really is what has built into our system these patient-unfriendly parameters that say, you have to have a deductible, because if you don't, people are going to go to the doctor too much or be put in the hospital too much. Hamza?
So I think one of the interesting things about the report was that, they recognize that every country has pros and cons. And one of the positive things that they outlined about the US was that we were a top performer in terms of delivery of, or the care delivery process is the verbiage that they used. Which is very interesting because, we seem to lead the pack in comparison to other countries. Still aggregate, we're lower in terms of all the other metrics, but in this one way. And then sort of towards the end, they talked about that perhaps this is the benefit of having, or sorry, not the benefit, but this is the result of having a vigorous pay for performance or value-based schemes that cause the sort of high emphasis on just the delivery, but not looking at the larger picture of making sure it's also preventative screens, other areas in terms of accessible, only just the pinpoint accuracy of, we just want it to be high quality.
I hope I understood that. The one thing, I think it's in this business of care delivery, that's where we, tell me again where we scored highly, care delivery of care.
The verbiage was care delivery process.
process. And then I think technology was mentioned, and that's the thing we think. And when we do our single payer presentations, we often say, well, don't we have the best system in the world? Don't we have the finest doctors and the best hospitals and all these technologies? Well, we do, but they're not getting to the they're not getting to the patients, or they're not getting to every patient. And we've just got so many uninsured, and that's one of the key reasons why the Commonwealth Fund gave the negative evaluation to say, we still have 26 million uninsured, despite all our high quality doctors and hospitals and technologies.
Well, I would say there's a question mark about the pay for performance having done anything really good for our system, because there are only one, it's very, very difficult to measure outcomes, and only certain outcomes are measured. And so it ends up like the educational thing, you teach to the test, and only those that are being measured come out better. Evan?
Yeah, I just wanted to second that. I think the value-based models can definitely help you check the specific boxes that these surveys might be questioning people with. But I think there's also a good bit of research that suggests that the value-based payment models disproportionately penalize primarily minority serving hospitals or chronically ill serving hospitals. So they may not be doing as much good as they seem to be.
Mm-hmm. I know one of the pay for performance criteria that has been shown to be not valuable is that hospitals are penalized for readmission of a patient within 30 days, which makes really no sense. I mean, you have to penalize a hospital payment, you have to assume that the readmission within 30 days was somehow the responsibility of something they failed to do or did wrong 30 days ago. And I think that's not true. So we don't have a proper evaluation. And I think there's even evidence now that criteria being applied has caused hospitals to put people into observation rather than into readmission, and has caused some deaths as a result of using this pay for performance criteria that doesn't really measure properly and is not doing anything good for us. The other thing on the value-based payments is that all of those experimentations that are taking place under the Center for Medicare and Medicaid Innovation involve a privatization process, because they include a middleman, an insurance company or private equity or venture capital third party in the process of setting up someone to evaluate and set the standards for this. So we indeed have a number of problems within our healthcare system. And, that's one of the problems, is that complexity makes it difficult for the American people to put their thumb on what is wrong and what do we need to do. And I think that's really important for those who study this, to help to simplify and to find the truth and help people to take a look at it in a way that gets us to a real solution. Evan, then Harriette.
I completely agree with that. Again, I think that issue kind of underlies not but one of the issues with Medicare Advantage, the Part C of the Medicare and Medicaid. Like, they have a very complex system of quality benchmarks and bonuses because they subscribe to a pay for performance value-based model that has time and time again been shown to cost way more than it should for no improvements in quality of care. And it really just kind of goes to give traditional Medicare a bad name because Medicare Advantage ends up costing more. People aren't happy with it. And then they confuse Medicare Advantage with traditional Medicare. And it just obfuscates the underlying problem.
Right. Right. Well, and I mean, we've all been talking about the role of the insurers and just the administrators. And it reminds me of an old graph that we always used to include in our presentations. I go back too far, I think, but where first of all, it would show the blue line showing the growth in the number of doctors over the past 20 years or the past 30 years. And then it would show the number of administrators. And there was just this mountain of lines showing how the number of administrators in our system had increased. And all those administrators cost money. And a lot of them also cause what? Complexity and often cause delay, and they're skimming off the profits as well. So, you know, I mean, we can't thank all those administrators if we've got a better delivery system. What did they call it? That we were high in care delivery. And that's where we were talking about the advanced technology and things like that, but you can't thank those administrators who just, and now we have those middlemen, the pharmacy benefit managers, driving up the costs of drugs.
Hamza?
Down on the middleman today.
Yes.
Yeah, it's definitely the middleman. I think one thing I wanted to touch on quick was the Center for Medicare and Medicaid Innovation. Like Kate pointed out, that there is sort of like a cap on how much money you can save, given just the nature of the multi-payer system that we exist in. And notably, since the center has been established in 2010, thanks to the ACA, there have been very few models that they have, well, they call them models of how they save money. There have been very few that have been implemented. And, you know, their idea is that, oh, we'll research them, we'll find them. And, you know, they always talk about how we're looking at it and, oh, this one seems promising. But then when you look at the numbers, none of them save any money because they're still
they're very little savings. Yeah. I mean, they brag on savings that they're not getting. Well, and then I didn't realize, was CMS set up under the ACA?
CMMI was set up.
Oh, CM. Oh, I know. That's no, I've forgotten her name. The one that used to, Liz Fowler, who was the assistant to Max Baucus when they implemented the ACA, and they wouldn't allow the single payer doctors to testify. And Liz Fowler has just gone, and she used to be an executive with WellCare or Anthem, one of those, Blue Cross Blue Shield or something. And then she just kind of one of those revolving door executives has gone up into CMS, and she's always coming up with ideas that don't ever save money, but they're trying to bring investors in, and they brag on public-private cooperation. Well, it's costing us too much money.
Yep, Liz Fowler is certainly a problem in her relationship. She was the person who, or one of the people who actually wrote the Affordable Care Act, and she came from the insurance industry, and she went back to Johnson & Johnson as, you know, a big person there, and now she has been appointed head of the Center for Medicare and Medicaid Innovation, which always does innovative plans that include the insurance industry. There is no thought of removing the insurance industry as the way we get to the problem, as the way we get to a solution. I thought that that was interesting that when you got to the end of the Commonwealth survey, they had a little section on reversing the dismal track record of the US healthcare system, where I think that they did a really excellent job of pointing out the shortcomings of the US healthcare system and how we are behind in all of these measures of outcomes and cost, et cetera. But when you look at their proposals, they're pretty generalized. They say simplify health plans, facilitate efforts to lower co-insurance and deductibles. That's pretty milquetoast stuff, you know. They say a more robust primary care system, well, that would help, but they never name the reason for all of this high administrative cost as being the profit. And they never say that it's the for-profit system that is the problem. I thought it was interesting. Here's one of their sentences. The proliferation of investor-owned entities that buy and sell primary care practices like tradable commodities deserves close scrutiny for its long-term impact on the cost and quality of care. Now, what do you think about that sentence? What does that say? We should look at what private equity is doing. I mean, don't we know what they're doing? Did it ever occur to you that we should exclude private equity from participation in our healthcare system? Hamza?
I think, like you mentioned, it's pretty milquetoast. They're just like, oh, you know, they don't really go the extra step of like, here's the way to solve the problem. It's more of like, we should do something about the problem, not offering the extra thing of like, what can solve it. I thought it was interesting that they did bring up private equity and sort of like the consolidation that's happening as a reason of causing administrative inefficiency. Like somehow the United States is the perfect storm of a number of bad things that all somehow just make all like the healthcare system worse. And I think private equity is like the latest and greatest of a terrible disease that's sweeping across the country in terms of not only just like small private practices, but also large hospitals that somehow in very necessary areas, in places where like just general populace depends on the hospital, private equity will swoop in. They will mess around with the financial statements. They'll make it, oh, it's a real estate business and you have to rent out the hospital portion. It will bankrupt the employees. And then all of a sudden you were left without a hospital. Right. And so simply looking at it is, you know, we've been looking at it for a while and now it's time to start doing something about it.
Agreed.
Well, and private equity coming even into physicians' practices. I mean, it doesn't matter whether I go to the podiatrist or, you know, only my eye doctor seems to be staying, and he's a bit of a renegade, and he's been staying out of being taken over by private equity. But private equity takeover of physician practices has, I think, caused a lot of physician burnout, you know, where they're trying to make you dance as fast as you can, you know, see patients as fast as you can, etc.
Evan?
Yeah, you're exactly right. I think that there was a KFF report that stated the share of private equity-owned healthcare providers from 2019 to 2022 in the US went up 39%. And the vast majority of those enforced global risk models on the providers that they owned.
Now, what does that mean?
Exactly what you talked about, where the physician takes on a lot of the risk in seeing patients where their payment is dependent on the number of patients that they see in a given window, as well
Right,
as,
and how many, for example, don't go back into the hospital, or how many
yes, and
whether they
essentially
control their blood pressure. I see what you mean. Yeah, okay,
maximum
thanks.
number of patients that you see in a day while minimizing the amount of expense incurred by actually treating the patient.
Wow.
That's right.
And
That's right, that physicians are losing control of the professional decisions in their practice because they are being forced by the entities for which they work. And I think it's now something like 75% or so of physicians who are employees rather than independent practice people. Hamza?
I think one thing that I want to mention also is oftentimes it is attractive to physician practices because one thing people say is innovation. Oh, they'll provide this latest and greatest technology. Oh, they'll provide this. But the trend of private equity causing a lot more problems definitely outweighs the small innovation that they see.
Well, I want to go another place, which most people don't talk about, but I am concerned that these groups of, like the Commonwealth Fund and the Kaiser Family Foundation, who do very good research and provide us with a lot of data. You know, they do these surveys, and in general, that it's good work that helps us, like this survey, which helps us to understand. But I'm going to suggest that one reason why these groups don't say, and the solution is to remove the profit within the healthcare system and go to a single payer system or an improved Medicare for all or a national health service, they don't say it because on their boards of directors are people who are in those very private equity companies that are profiting from the healthcare system as it is. And I just took a look today. I saw two of the members of the board of directors of the Commonwealth Fund. One is Dr. Mitchell Blunt. He is the founder and CEO of the healthcare investment firm Consonance Capital. Consonance Capital is a healthcare investment platform. It does private equity investments, which include et cetera, et cetera. Another is on the board of the Commonwealth Fund is Alan Jones. He's the managing director at Intermediate Capital Group. He previously served as a managing director and vice chair of private credit and equity at Morgan Stanley. So this is one of our problems, is that the institutions that we rely on for the data aren't going to lead the battle for the kind of healthcare system that would really solve the problem, and that has to come from people who are independent of those private property, private equity, and private profitability interests. And that's why it's so important for organizations that are representative of physicians or citizens or people or communities, that we amplify those voices in a way that can give us, rather than this community that is so infested with the investor-owned private equity. Harriette?
Well, and you know, we kind of hope that Saint so-and-so, a progressive politician, is going to come forward and going to take us there. It's going to say this is the end of private insurers, et cetera, et cetera. And the problem is we're up against all that lobbying money, all the power of AHIP, you know, the insurers lobbying group. And I mean, even people, I mean, even with the ACA, yes, the ACA did help with pre-existing conditions, and it did help with the expansion of Medicaid. However, I mean, if you have Medicaid expansion, which at least we have here in Kentucky, however, instead of Medicaid expansion, we just should have gone to single payer healthcare and covered absolutely everybody and said, this is it. In my, this is my country, and to do what I should for my country, I want absolutely everyone covered. And, it's not happening. We need someone very gutsy and backed up by the grassroots, groups like ours.
Hamza?
I think, we are getting to the core of one of the reasons this fight is taking so long, and really requires lots and lots of people who are both knowledgeable and are willing to put in the effort. Because the interests control not only government, but they also control just like basic things like you mentioned, the report like this. It's not going to go the extra step of this. And interests work in a large number of places, right? So pharmaceutical companies, like you mentioned, pharmacy benefit managers, they control the nature of studies, they control the nature of like how drugs are developed. And so it's sort of like a large interest, like it seems to control a large part of the healthcare system. But, something like single payer, improved Medicare for all would address a lot of these issues. If it got to a place where it was where it needed to be. I think the other part of this is also that, it needs to be, the bar needs to be high, is what I'm trying to say. Of like, there needs to be adequate coverage, there needs to be affordability, there needs to be great access built in, because on the way, it will definitely get watered down if we don't keep up the fight. We don't make large demands, given the nature of how invested these interests are in a number of places.
Right. I mean, there are even people in Medicare Advantage engaged in fraud. I mean, they've got these elderly patients, and Medicare gives them a certain amount of money to cover those patients, and then they deny the care, and the insurer keeps the money. I mean, you just think, this is fraud. How are they getting away with it? And even when they get called out on it, people just say they were charged with fraud, or I never remember the amount of money they've overcharged Medicare, somewhere in the billions right now, isn't it?
Well,
And
it's right. It's 88 billion a year annually, according to MedPAC, and PNHP's study says it's as high as 140 billion. So it's phenomenally high.
right. And I mean, it's white collar crime, isn't it? Just anyway.
But you see, nothing ever happens to them when they catch them, or they pay a fine and they sign a settlement where they don't admit to any wrongdoing, and they continue to function within the healthcare system. So that is indeed a big problem, that the private insurer, all of them have committed millions and millions and millions in defrauding Medicare. Paul? And then
I think when that happens in the other countries that we're talking about today, I think people actually go to prison. And today they pay a fine and deny any guilt in it and go on their merry way.
In other countries?
You said they go to prison.
They go to prison in other
countries.
countries.
Right, in other countries. You mean our people just keep on functioning, and they consider it the cost of doing business, right?
In our country, they go to the U.S. Senate, like Rick Scott.
Yes, exactly.
Medicare, and he paid a fine.
Right. Our younger medical students might not know, but Rick Scott was just hated in Louisville because so many, even I don't know the whole story, but he had a record of Hospital Corporation, was it, doing something awful while he was here in Kentucky.
Evan, did you?
That's pretty much exactly what I was going to say. back in August, I think, the DOJ sued UHC for an alleged $2 billion in Medicare Advantage upcoding fraud. And not the first time it's happened, not the last time it's going to happen. They're going to pay a fine. If anyone ever does get fired, prison's not really on the table, but if they do get fired, the revolving door of industry will certainly allow them
Pick them up.
to pick
Yeah,
up a position at a private equity firm.
right. But people still sign up for United Healthcare because AARP recommends them. And people have been so duped by AARP that makes all kinds of money by ripping people off with United Healthcare. The one thing, I know you guys have gone through all these, the reasons we did so poorly in this analysis, but can we, I know Kay always talks about, our mortality rate, the fact that we are, what is it, living sicker and dying younger. Let's have another little talk about that. I mean, our death, its mortality rate.
Yes, Evan, I think, has it.
I wanted to talk about this to begin with. Yeah, the health outcomes domain metric that was included in this study, they broke that down into two categories: population health measures and mortality amenable to healthcare. So I think mortality amenable to healthcare could largely be solved by getting rid of the barriers to entry. Like, people can't afford going to the doctor, so they put it off, or they start rationing medications or skip a refill. And that is the definition of mortality amenable to healthcare. That's all preventable deaths that
Can I just interrupt just for a minute? That was something I never understood. Mortality amenable to healthcare. It means they wouldn't have died if they had had healthcare. Is that how you understand it?
It's defined as deaths that were entirely preventable or treatable with adequate and timely medical intervention. Had they gone to the doctor in time, had they gotten a prescription and taken that prescription like they were supposed to, they would not have died.
Right. Well, I just think, that's so important. And in Kentucky, now, I don't know if you've heard talk of this in some of our Kentucky counties, the mortality, it's not the rate. When you talk about the age, I'm not using the right term. Come on, help me with this.
Life expectancy.
Life expectancy is so low in some of our counties. I really am getting too old to deal with all these terms, and you guys are very patient with me. Let's talk a little bit more about this life expectancy compared to the other countries and within Kentucky even.
Evan?
Two of the metrics that really jumped out to me as being just widely skewed in the US were infant mortality rates and maternal mortality rates. I think they're excellent proxy measurements for how effective your healthcare system is in general. If you're not taking care of mothers and infants, what are you spending money on? And the US performed horribly in both of those. And I actually have a couple years worth of OECD data on both of those measures, because we have for a number of years performed much, much worse than pretty much every other Western or industrialized nation in the world. Even the CDC in 2019 released a report that 4 out of 5 maternal pregnancy-related deaths were preventable. So it's, 80% of them were preventable. And personally, I think a lot of the data points to proper access to care. Are you getting, just like prenatal health screenings and stuff, are you going to the doctor in the year after you had your kid? If you can't afford it, if you don't have even like access in terms of transit, then no, you're not.
Right.
The other part of that metric that I thought was really interesting was the population health related deaths or population health outcomes. They calculated life expectancy at birth, measuring the distance from the 10-country OECD average. I kind of want to talk about that through the lens of COVID-19, specifically with masks. I'd like your guys' opinion on how we handled COVID-19, but even post quarantine and lockdowns. We've kind of in the past few years done a 180 where we had these mask requirements in certain places. And at least to me, I felt like there was a certain kind of communal public health oriented mindset where people were cognizant of this and willing to go out of their way and really just cared about it in general, compared to now where we have the exact opposite. There are 16 states with mask bans active in certain counties.
Yes.
A notable one is Nassau County in New York, who just recently had some of the first confirmed Mpox cases in the US. Like, even COVID-19 aside, masks are a very important public health measure, and we seem to be actively ignoring them as public health tools, and that will just continue to erode our already dismal life expectancy.
Thank you, Evan, for contributing that. I'm sorry, but we are now at the end of our recording time. And thanks to everyone for participating in this very informative and very important session for Kentucky Single Payer Radio. And we will see you the next time.
What an excellent show. I want to thank everybody that participated today, and I hope we can do this again real soon. If you would like some follow-up, such as the links that we were discussing on the program, you can always go to our website, which is kyhealthcare.org, where there'll be a post on today's radio program with the links included, so you can actually read up on what you've just listened to.